Rubio, vamos a darle la palabra a nuestro presidente, al doctor Miguel González, el primero que... Ahora, ahí viene el micrófono.
Okay. All right, say who you are. So the question is, the question goes for the whole panel, because it was stated that regardless of an individual high risk in primary prevention, which is the position in patients with kidney failure regarding statins?
Specifically is how do we address patients with kidney failure and statins, and so
Está sin micrófono, me parece.
I'll speak first to our current guidelines, but I'll also share my personal feeling. And I'm on the writing committee of our planned 2018 ACC-AHA lipid guidelines. So again, I'll qualify if I make a statement that this doesn't reflect the guidelines in progress for us in the U.S. Our current guidelines, the 2013 guidelines, found several populations where it just says inconclusive evidence. So this is the heart failure population, stage 3 or 4, and patients with CKD. Now, so those are our current guidelines, and Dr. Unberg and Dr. Morris can comment as well. On a personal level, because I know the ESC guidelines, the Argentinian guidelines, many others, highlight high-risk groups. I do think in patients who have proteinuria and patients who have CKD, epidemiologic data tells us this is a high-risk population. It's a little complex in the CKD patient. If you look at moderate CKD, the SHARP trial, I believe, shows risk reduction in patients who have end-stage renal disease. TNT and others show no significant benefit. So this is one population where, at the highest risk, despite that, statins so far have no clinical proven benefit in randomized controlled clinical trials. So I don't know if, Jamie, if you want to.
Yeah, I think right now also actually the National Lipid Association recommendations included chronic kidney disease as a risk factor. And so I would look at it as something I would utilize to help further stratify risk assessment rather than to use as the sole initiator of therapy, much like a coronary calcium score, or maybe where we're moving with lipoprotein A. These are, once you've done the initial risk assessment, it might help you further determine the intensity of therapy, but maybe there isn't enough evidence yet to be the sole prognosticator of statin benefit. And part of that is, I think, because of the heterogeneity of kidney disease. At the end stage spectrum in stage 5, I believe that the type of atherosclerosis is one that might not benefit as much as the cardiometabolic risk that you were discussing in the earlier stages of chronic kidney disease.
Simplemente agregar que
I would just want to add that these are very high-risk patients, and European guides put the patients that have glomerular filtrates less than 30 as high risk, and between 30 and 60 as high-risk patients. So, we've said it, hemodialysis patients have no indication for statins, and when you use them earlier, you have more benefits, but of course, nothing is conclusive yet. We will now take a question via internet by Dr. Roberto Añasco. I think I know who he is, from the province of Corrientes. He asked whether you have to perform primary prevention beyond 80 years old. So those who are in a population over 80, whether you need to perform primary prevention? Well, it's an issue. It's a controversial question, depending on where you stand. Of course, age is a key risk factor in any of the scores or guidelines. We see that age is part of, a huge part of the cardiovascular risk. And I don't think it's a limit or a threshold. There are a lot of people who are 80 who are great, and people who are 60 who are very old. So I don't think that age is a factor. It's not a restrictive factor to initiate prevention therapy. Patients who are 80 or 85 usually have other things, hypertension, hyperlipidemia, diabetes, etc. Therefore, to go to your specific question, 80 years old does not restrict the start of prevention.
I would very much agree with those comments. Although we suggest risk assessment, our approach to risk assessment and care needs to be individualized. Now, there are some patients, if you go to your risk estimator, they're too old to risk assess. And so they've survived past that age of risk assessment. Now, that being said, when you talk to the patient and the clinician-patient risk discussion about their goals of care, they may say, "Doctor, I'm 80 some odd years old. I've lived a wonderful life. I'm not that excited about taking medicines, but one of my goals is not to have a stroke if possible and survive and be a burden on my family." And so as you think about goals of care, you can approach that risk along with the patient. So I would very much agree. There are patients who are 90 that are very robust and are excited to live many more years of quality life, but somebody can be demented or terminal and have comorbidities at a younger age, and that our goal isn't necessarily to have them live longer, it's quality of life.
I was just going to make one other comment. You know, we've now had a large number of patients that have been included in randomized controlled trials that are definitely above the age 65, as well as patients up to the above the age of 80. And when you look in meta-analyses as well as the individual trials, there is consistent benefit in patients who are older adults. And so I think the point that both Dr. Lehrman and Dr. Sperling made, which is you need to consider the patient's baseline level of health, their prognosis, and their priorities as you make a decision regarding statin therapy.
Sí, yo querría hacer un pequeño agregado.
I would like to add something, if I may. When you talk about the average of life expectancy, well, that's from birth. The average expectancy is around 78 years in Argentina, but whoever reaches 80 has an average of 86 years. So life expectancy, the older you get, the longer is your expectancy. So that makes us very hopeful, all of us sitting here, don't you think? Doctor, you want to add something?
So I agree, and even in patients with familial hypercholesterolemia, as they get older, their risk actually comes back down to those who don't have the condition, almost as if they've survived the risk. The best thing I think I can do for my older patients is to make them younger. But getting older probably is the safer thing for them. And I was able to chair a session at AHA on lipids in the elderly. It was a wonderful session looking at many of the things that Dr. Morris just mentioned about the cumulative evidence of these drugs in older patients being safe, and just reminding patients that they're not going to live longer if they take something like a statin, but it may potentially reduce the risk of a life-changing event like a non-fatal stroke, and I think that's very important.
Doctor Lozada, ahí tenemos.
Dr. Harris, Morris, we have a court.
En español porque lo están traduciendo.
Okay.
we have a cohort in the southern cone of South America, which is ECAS, which Dr. Lerman showed, and it has over 50% of people with 3 risk factors and 58% of patients that have dyslipidemia, and this also includes the rest of Latin America, a lot of low LDL-C and high TGs. So my question is the following. The recommendation from the ACC 2013 was towards the general aspect, and it was very efficient to make the generalization and clinicians to prescribe statins. However, we have something that applies to us, which is the HOPE-3 study, where apart from the classic, in HOPE-3 they included the waist hip index, dyslipidemia, and moderate or mild kidney failure or kidney disease. So these are very common characteristics in the Latin American population. Therefore, because this study has the same populational focus as the ACC guideline, my question is, do you think that this will be taken by the new guidelines, the HOPE-3 study, and do you think that this will have an impact? Because it would seem as if, this could be a very strong impact study in our population with TGs, dysglycemia, and low HDL-C cholesterol.
I'll make an initial comment, and then I'm going to turn it over to my other colleagues as well. But I think one of the things that I try to emphasize when I talk about the 2013 ACC-AHA guideline is that was by design a very narrowly focused, minimal guideline, foundation guideline. They were only allowed to use high-quality randomized controlled trial evidence. So the scope of that guideline was more narrow than any guideline that had ever been published. And that was, so I considered them a starting point. And then, for example, other guidelines, such as your national guidelines, the National Lipid Association in the U.S., the kidney disease guidelines in the U.S., I think that gave us that nuances of these more complicated patients, exactly like you're discussing. Now, I'd like to turn it over, because my understanding is that the new format, much like the new hypertension guidelines in the U.S., which, while controversial, were extremely comprehensive about all aspects of hypertension. I think we're going to see a new format to the upcoming lipid guidelines from the U.S. I'm going to turn it over to Dr. Sperling, who's actually part of that guideline.
Yeah, so the answer is absolutely. HOPE-3 will be considered in the guideline. And as Dr. Morris said, the 2013 guidelines, there was a lot of questions about it and controversies. They're a foundation for what we're going to build upon, but our guidelines in progress are much, much more comprehensive. Now, to address that population that you outlined at high risk in southern Argentina, I'll come back to the slide I showed of the bell curve distribution in a population. And so before we talk about individualizing care and risk, this is a great opportunity for public health initiatives, for population health. And so we can begin to work on making that a healthier population from their time of birth, young adulthood, and the cumulative risk they're experiencing. But clearly, this is a population that needs comprehensive risk reduction, beginning with lifestyle and behavioral approaches. Even if those are modest, you can have significant impact. And a population that it sounds like needs, multimodality risk reduction, and how you decide to go about that with medical therapies. This becomes an art and an individualized discussion with the patients. Oh, I'm sorry. Oh, I'm sorry. Oh, yeah.
No.
I just wanted to add that Hope 3 leaves teaching regarding the use of statins without considering the LDL cholesterol levels. There was no requirement on entry or recruitment for the LDL-C, and patients were treated during almost 5 years or 4 years and a half with statins of moderate intensity, 10 milligrams, and the benefit was quite clear in a population of intermediate risk. It was not low risk, it was an intermediate risk population. So this evidences, once again, the benefits of statins. After the hypertension study, somebody said that it should be over-the-counter medication. But I think that these are fantastic drugs. And can I ask something, please, if you allow me? Short. I'll make it short because we have a cataract of questions. What do you think a poly pill for primary prevention, including statins and something extra?
I have mixed feelings about it. From a population health perspective, I can see the potential benefit for, in particular, countries which have huge communities of individuals living in rural settings with minimal to no access to continuous health care. So I do think there are some benefits. I also, on the other hand, am somewhat more concerned about patients who really need to be identified, who are at very high risk and need more aggressive therapy. And also there are individuals who are at quite low risk and it's not necessary. So I think the poly pill may play a role. I'm not 100% certain that it's going to come to reality.
I think my other concern about the poly pill goes back to what I mentioned earlier, was the importance of documenting expected response to therapy. We didn't show the slides today, but some recent great data from the Jupiter trial showed that there was a dramatic variability in LDL response to the same dose of the same statin, and that the degree of response is what predicted the benefit in cardiovascular outcomes. And so in those patients who don't respond, you need to do something else, and that includes with a poly pill. There are going to be some patients who don't respond. And so you're removing that part of the equation, and while I understand it may be better than nothing, I don't necessarily know that it's as good as it could be.
Sí, brevemente. Sí.
The goals for the poly pill are both compliance or adhesion and cost. This is the reason, or these were the reasons why we came up with this poly pill idea. The evidence published so far states that, yes, of course, if you have the poly pill, there's more compliance and less cost. However, or such as that if there is no compliance and cost issues, I think that the poly pill plays no role whatsoever. In certain population sectors, we have them in our country, we have those restrictions for compliance and cost. This might be a resource that's better than nothing.
I can comment if there are more questions, but I think the poly pill clearly is best utilized in secondary prevention. In primary prevention, there's if you're approaching it on a population-wide level, there's a spectrum of risk, and so we definitely want to maximize benefit, but on the low end of risk, we're subjecting individuals potentially with low cardiovascular risk to medical therapy throughout the rest of their life. I think we underappreciate the importance, though, of compliance or adherence. Even in secondary prevention patients, we know without an appropriate explanation for therapies and an appropriate partnership, that clinician-patient discussion, many patients, even within 6 months of myocardial infarction, have stopped their statins and other therapies. So I think this is one of our biggest challenges in care.
Bueno, vamos a pasar a una pregunta que que viene por internet es...
Let's go to a web-based question from Dr. Lopiccolo from the Casilda Heart Association. We thank you for your question, and he asks, if we wanted to have the value of the hepatic enzymes or muscle enzymes, as of which then statins should be stopped.
So as far as hepatic testing or muscle enzyme testing, CK goes, I think in healthy or asymptomatic patients, it's not something that I would require or ask people to do. The FDA in the United States has said that you don't need to check liver function tests in patients taking statins. And as far as routine muscle enzyme testing, it doesn't seem to predict who will or who will not develop a problem. We really only reserve it for patients who do develop complaints of myalgias and then consider muscle enzyme testing in those patients.
I would agree with what Dr. Underberg said in terms of approach to general patients. I mean, we would not routinely check a CPK or hepatic enzymes for follow-up in individuals. Although in people that have their transaminase levels elevated at least 3 times above the upper limits of normal, we should consider holding therapy for a period of time, but coming back and reassessing the reason for the transaminase elevations. A lot of our discussion here today focused on metabolic risk, and there are many individuals with metabolic risk that have hepatic steatosis with mild elevation of transaminases, and frequently these patients are looked at non-candidates for statins because they have baseline liver abnormalities, and they certainly are candidates for statins. Safe in this population, and trials underway looking at outcomes. And then CPK, I mean, it's the rare patient that has rhabdomyolysis. There's a condition, and we look at CK and muscle issues more now as SAMs, statin-associated muscle symptoms. There's a rare entity called statin-associated autoimmune myopathy, which is very, very rare. And in these individuals, you not only have very large elevations of CPK, you have muscle weakness of the proximal muscles, and you have HMG-CoA reductase autoantibodies that are measured. So this is, but very rare to see rhabdo or autoimmune myopathy.
Coincido.
I agree, hepatic enzymes elevation is quite rare, but if it's 3 times the upper level, then you have to suspend. And then for the muscle enzymes, if they are symptomatic and even 5 times the elevation, you might examine. If it's 10 times, you need to terminate statins.
¿El público?
Mi nombre es Adrián Charaz.
My name is Adrián Charaz. For Dr. Sperling, you said in your presentation that patients that have over 10% risk, the use of aspirin for primary prevention was beneficial. What's the role of aspirin in primary prevention?
So the 10% comes from not the ACC AHA guidelines right now, but the U.S. Preventative Task Force looked at least a decision point where for primary prevention, the benefits of low-dose aspirin would outweigh the risks and side effects. So really the threshold for aspirin in primary prevention is a higher threshold than statins. We need to recognize that in terms of risk benefit or net clinical benefit. That discussion again, there are different goals of aspirin therapy in primary prevention, and those should be discussed with our patients along with risk. But really the decision for medical therapy in patients at 7.5, 8, 9% risk, the first discussion should be maybe consideration of statin as opposed to aspirin plus statin. But you can go and have a discussion about goals of care, lifetime risk, and these are not all these cut points, 7.5%, 10%, realize there's a spectrum of risk in all of our patients, and these are not absolute all or none, so your patient has a 9.5% risk and you wouldn't start an aspirin, and the 10.1% risk and you would. That's a discussion to have with your patient.
How do you use aspirin in primary prevention?
Aspirina en prevención primaria tiene un rol muy limitado.
Aspirin in primary prevention has a very limited role. I think that the accurate prescription would be multiple risk patients with a significant risk score above 10% and having excluded bleeding risk. I mean, risks of gastric diseases or other types of diseases, and that is basically the prescription: high risk and lack of bleeding risk. Well, we have another question on the internet from Dr. Castro. Unfortunately, I don't know the source where he's from, and he asks, for primary prevention, those patients with low or moderate risk who achieve their goals in several controls and are adherent to non-pharmacological measures or treatment, in those cases, can we suspend the prescription for statins? Well, the lifestyle is the ground, is the baseline for primary prevention. Food, healthy food, not smoking, physical exercise, and periodic controls. In general terms, if we abide by this, and this is a work more than physicians, it has to do with the health authorities. Primary prevention is a community issue. Physicians, of course, we are vectors, but health authorities, scientific societies, the mass media, social network, schools are the real vectors for primary prevention. And all of this basically address to changing lifestyle, food, physical activity. In those cases, I believe that pharmacotherapy, statins, could be, subjected to the strict compliance with the good quality of life behaviors. No, yeah, please go ahead. I'm Ernesto Duranto, and a question I asked Chris Cannon when the improved trial was presented here in Argentina. I asked him, so are the LDL targets or the dose for statins? Why can't I use moderate dose of statins in my patients when I get LDL's levels of 50? Now the question goes to you.
Well, the IMPROVE-IT trial demonstrated benefit. I think, in my mind, what it showed me was that you could add a non-statin safely and achieve further LDL risk reduction. The population studied in IMPROVE-IT probably is not the population most people would have originally thought of using ezetimibe on top of a moderate dose statin, although at the time the trial was designed, they were actually meant to bring the patients up to even 80 milligrams of simvastatin, but that actually was changed as the trial went on. So when I look at that trial, what it says to me is that A, the benefit accrued after a year, meaning that I think you could use it in stable patients as opposed to unstable, and that further LDL lowering was beneficial, albeit small. And so again, I don't know that the role for ezetimibe in that particular population of patients is that robust. It's more what the trial showed us about LDL lowering in general, rather than how it applies to that specific population. And that's the best way I can answer it. I don't know if my colleagues have any different views on that trial.
Yo creo que una parte de tu pregunta iba a...
I think that part of your question was whether we could lower the statins doses But long ago, it was proven that pleiotropic effects are more important with the highest doses, and we cannot deny these effects in terms of the statins, in terms of swelling or inflammation and other beneficial effects, etc., etc. I think that the acetamivir is a drug that can be added when you have first used the highest dose of statins tolerated. On the other hand, for example, comparing atorvastatin 10 versus the 80, and this happens with other statins. There's a recent trial with pitastatin, I mean the TNT trial, that clearly showed the benefits of the highest statin dose. So there are no controversy now regarding that point. So, okay, let's go to a question from Dr. Juan Pablo Alviso from San Luis. He says, we know that statins or statins are not all the same, not only for the LDL reduction power, but based on side effects like the appearance of diabetes. Based on that, in primary prevention, should we start with the statins, with those with the lowest diabetes incidence, like pitastatin, and on the other hand, this drug is not available in the Argentine market?
Well, first of all, new onset diabetes in the setting of statins, so far the data shows that statins themselves don't cause diabetes, but in people who have underlying propensity for diabetes, whether that's family risk, they have metabolic syndrome, there appears to be a change in internuclear signaling that is very real. And so the statins can nudge people over the edge. It comes back to my presentation in terms of assessing the degree of risk of an individual in primary prevention. And so I wouldn't necessarily choose my statin based upon the chance of nudging a patient into statin-related new onset diabetes. I would choose my statin based upon the risk of the patient and the need for either aggressive or modest risk reduction. It is an opportunity, though, if a patient's worried about diabetes in the setting of statins, to come back to that discussion and talk to them about the importance of diabetes prevention, using the tenets of the diabetes prevention program: regular moderate physical activity, healthy diet, modest weight loss, and talk about really the power of risk reduction in the development of diabetes. At the same time, you talk to them about risk reduction for cardiovascular events.
The other interesting area of this is in the genetics space, where patients with familial hypercholesterolemia and defects in the LDL receptor seem to be protected from diabetes. Yet mutations that impact the LDL receptor, such as the HMG coenzyme A reductase gene or the PCSK9 gene, seem to be associated with an increased risk of diabetes. Yet when you look at cardiovascular risk reduction, it turns out that the benefits accrue to a greater extent than the risk of diabetes. And the risk of diabetes is simply accelerating a process that's already going to occur. So I would have to agree that I would not adjust my statin dose based on any theoretical concerns about diabetes. I would adjust it based on intensity of therapy and the risk of the patient.
Sí, coincido totalmente.
Yes, I fully agree. I believe that we don't need to change the clinical practice thinking about the risk of diabetes. The benefit is huge, and what my colleague mentioned is very clear. Genetic trials, there's a very interesting trial from Fevens with genetic variables probably inhibition or GMR reductase or maybe could lead to a highest diabetes risk in patients with a tendency to that. But decreasing infarction with both interventions is way bigger than that small percentage. Well, we are running out of time. I would like to ask this question by Dr. Rogelio Aguilar Castro from Bolivia. I would like to underline this. So we welcome our colleagues from Bolivia, and in questions and recommendations for therapy with statins are also applicable to children with increasing LDL. I understand they are. If a kid with high LDL is a patient that belongs to a family with hyperlipidemia in his family, so the benefit of the statin does exist in these cases, and this should be prescribed in tandem with pediatricians.
So in general, statins have been proven to be safe in adolescence, not affecting physical or mental development. That being said, coming back to absolute risk, the majority of children, their absolute risk is very low over the next 10 years. But we can talk about lifetime risk. And so certainly a child of an individual with proven familial hypercholesterolemia or a child with signs of familial hypercholesterolemia, absolutely, I would have no qualms beginning statin therapy at a very early age, recognizing that we can reduce the risk of that individual going on to have a cardiovascular event in their lifetime dramatically. And so it wouldn't be ideal to wait until they become 25, 30, or 40, especially with a family history of events at a young age.
I would just add to that, because I don't think I have anything more I could add to the pediatric aspect, that all too often young women have their therapy delayed with statins because of concerns about the potential for childbearing. And so I think it's as important for young women to be treated early once that has been determined also.
Si me permiten, quería agregar una pequeña frase que leí en un trabajo.
I would like to add a small thinking that I read by Drs. Brown and Goldstein, who found out the LDL receptor, and they got the Nobel Prize. And it says, the lowest, the better. We should ask the lowest, and the long-lasting, the better. But therefore, in a teenager with a high cholesterol, the lowest period of time this patient is exposed to the hypercholesterolemia, the better for his future. And I would like to ask something shortly to support that. There are records that use of statins of moderate or low doses at early stages bring more benefits than beginning on the 20s with high doses, or in the 25s, and beginning at the early adolescence, or even before 10-year-old. So we could think that risk at the age of 40 or 50 for that patient could be equivalent to an individual without hypercholesterolemia. So the benefit is large. Therefore, we don't have to be afraid of using the statins at early ages. And this has been proven from ages from 6 to 7 without any problem whatsoever. Well, we're going to have to round up and finish the Q&A. I would like to thank you. We are going to send those questions that have remained unanswered. We have from Catamarca, Piedma, 12. So we thank you all very much for your broad and active participation country-wise in this webinar. Personally, I'd like to thank you and the Society, Argentine Society of Cardiology, and also to the Argentine Federation of Cardiology, to the ACC, and also give you for your final thoughts, give the floor to Dr. Pamela Morris, thanking her so much for being in our country.
Thank you so much to all of our colleagues here in Argentina. I cannot thank you enough for your hospitality and for your attention. I wanted to make one comment and one observation, which is what I am amazed by when we share knowledge like this is how much more similar that we are than different. As cardiologists around the world, we are struggling with the same issues. We're struggling to prepare meaningful guidelines. We're struggling to implement evidence-based guidelines. We're struggling with patient adherence, both to lifestyle and to medication. And I think when we collaborate like this, we are more likely to come up with meaningful solutions to reduce cardiovascular burden around the world. So thank you. I also wanted to point out to all of you who are participating, I encourage you, the way we can make the next 2 webinars meaningful to you is through our pre and post assessments. So if you could go to the post assessment at www.acc.org/AR2. That will be very helpful to you in making them more meaningful. So with that, I guess we can conclude.